Good afternoon. I've been tasked with keeping you awake as you digest your lunches. So myocarditis, what I'm going to talk about, by the end of this, it would be helpful if you can apply updated criteria to your cases, your samples, be able to identify other types of myocarditis, and I thought I'd do a little bit on immune checkpoint inhibitor myocarditis as a bit of a hot topic in the last few years. So we'll start with going over the history of lymphocytic myocarditis criteria. I think it's still helpful to understand how we've got to where we are today. Go over the updated criteria, checkpoint inhibitor myocarditis, and sort of talk about some of the causes and outcomes of myocarditis. In doing this, I went down some rabbit holes I thought actually might be worth sharing rather than just being random rabbit holes. So I'll come off on some diversions on the way, but only brief ones. This is a 1995 definition the World Health Organization did for myocarditis, but they put it in the context of inflammatory cardiomyopathy. So, inflammatory cardiomyopathy is a disease of the heart muscle caused by myocarditis, which they've given a definition there, but without any real criteria for what to call it. So they talk about having established histological, immunological, and immunohistochemical criteria, but have left it to the wider community to work out what those criteria are. And there's a whole lot of other things there, the different types of it. HIV is interesting. So in South Africa, they had a lot of dilated cardiomyopathy because of HIV, which has disappeared since antiretroviral. So it's a changing picture over time. So let's go back in time to the myocarditis. So in the 1980s, I was a small child, believe it or not. If you said to me Dallas, I would have thought of the long-running American drama series with J.R. Ewing there, Texan oil man, and his family. American's oil drama. You can make your own comments on that. So the Dallas criteria were the first criteria for myocarditis. This started, going back to Rob and Joaquin's talks, this started with dilated cardiomyopathy. Patients presenting acutely with dilated cardiomyopathy, they found that some of them on biopsy had inflammation there. So these were inflammatory cardiomyopathies, back to the WHO. So these were biopsy criteria, and you needed at least 5 biopsies to make a diagnosis. And the definition was an inflammatory infiltrate of the myocardium with necrosis and or degeneration of the adjacent myocytes, not typical of ischemic damage from coronary artery disease. So you needed inflammation and myocyte damage. They also had a borderline category, which is if there was inflammation but no myocyte damage. It doesn't actually specify which cell type, so this could apply to lymphocytic, eosinophilic, giant cell, myocarditis. So it doesn't just for lymphocytic. They also had different classifications for first and subsequent biopsies. So the first one, you could have myocarditis with or without fibrosis. So that's inflammation, damage. Borderline or no myocarditis. If you've got myocarditis on the first one, you can then have a subsequent biopsy looking for ongoing. So this inflammation is the same with or without fibrosis. Resolving, so there's less inflammation with or without fibrosis, or it's resolved. So there's no inflammation left. There may or may not be some fibrosis as a marker of that. So that was in the 1980s. It started in 1984, although it's difficult to get anything in the literature. Well, I found it difficult to get anything before 1987. I think the 1984 was in a now defunct journal. In 2006, there's a quite widely cited editorial by Borman, it's the one at the bottom there, which was headlined "The Death of Dallas," which again brought me back to J.R. Ewing. One of the long-running storylines in that serial was who shot J.R. J.R. got shot. So Death of Dallas. 5 biopsies misses about a third of the cases that, for other reasons, the clinicians were convinced had myocarditis. So the sensitivity was in doubt. There's poor inter-observer agreement on this. It's based on interpretation of morphology, and so the inter-observer reproducibility wasn't great. And what the pathologists were telling the clinicians didn't seem to affect the patient's response to treatment or their outcome at the end of the day. In 2013, the European Society of Cardiologists produced some new criteria. Interestingly, they've gone down to 3 biopsies, which doesn't seem to make sense if 5 is still missing them, but at least 3 biopsies for histo, but having more for freezing or in RNA later, so you can do viral studies or other studies onward. To diagnosing viral myocarditis definitively, you need to demonstrate virus in myocardium. Serology doesn't work very well for it. The writers of those criteria obviously have never met a hemopathologist because they want a large panel of 3 immunohistochemical stains. So CD3, CD68, and an HLA-DR. I've never done an HLA-DR. I believe our neuropathologists still have it available. Have you ever done an HLA-DR?
Not for years.
No. But that was their large panel immunostain. The criteria, I've never quite understood the wording. So it's at least 14 leukocytes per square millimeter, including up to 4 monocytes. So as if that's you stop counting monocytes at 4, and at least 7 of them are CD3 T cells. So this is based on counting immunohistochemically stained cells. So that the idea of that was this would make it more reproducible because you've got brown and white, count them, and you've got an area, a defined area. They took out monocyte damage as a criterion than that, so it's all about counting cells. There is a more recent position statement from the ESC on myocarditis and pericarditis. It sticks with the old one, but does say that we need new criteria. I don't think these have ever really gained full buy-in from pathologists. So one of the outcomes of who shot JR, JR didn't die, and nor did the Dallas criteria. They're still widely discussed and I think still widely used, to be honest. So this is the 2025, this is their latest thing from ESC. New quantitative criteria are presently required because their criteria have been questioned by cardiopathologists, so that's us. But they do give a nice table in their paper there about the different types of myocarditis and the cells you'll see with them with your large immunohistochemical panel. The HLA-DR seems to have dropped, so you've got 2 stains now. A CD45 can be helpful as well. True. So following 2013, 2019, 2020 came along, COVID-19. There's a lot of publications around this time of myocarditis in COVID, some of which were really good going myocarditis, but some of them, the criteria they use seem to not be entirely objective. And when you looked at the published data, they weren't convincing myocarditis. So some of these cases probably weren't really myocarditis. They were often positive on European Society of Cardiology criteria, so the cell got the cells, but not on Dallas. The cells were there, but they weren't actually doing any damage. And there was concern that the ESC was then being used to identify non-specific inflammatory changes in sepsis, rather than genuine myocarditis in some of those cases. So that's a little diagram of COVID-19 and the heart. So that's the Basso paper there. In their series, I think they got lymphocytic myocarditis in 14%. Mark Halushka's, they're looking at across different studies, probably think it's more like 2%, much less common. But there's this diffuse macrophage infiltration at the bottom there, that seems to be causing some problems. So, with that in mind, the Association for European Cardiovascular Pathology and the Society of Cardiovascular Pathologists got together and decided we're going to try and see if we can improve on what's there at the moment, build on Dallas, build on ESC, and try and produce something that's a bit more specific and reproducible than what had come before. So it's a bit mid-Atlantic. It's got a bit of both Dallas and European. There were lots of meetings where people discussed it. On the published papers, if you go online, they've actually published a supplementary detail on the things they couldn't agree on, which I think is quite interesting. The final meeting was in the Seaport area of Boston, so they've been sort of christened the Seaport criteria. Boston criteria are already taken for any neuropathologists. That's cerebral amyloid angiopathy criteria for Boston. Before they got onto the criteria, they looked again at how many lymphocytes is normal in an endomyocardial biopsy, and some of these were cases taken for amyloid or for cardiomyopathy. I think some of them looked like they were probably from a research study where people had endomyocardial biopsies for research purposes, but none of these were diagnosed with myocarditis. So median, it's about 2 or 3 T cells in the busiest high-power field. So rather than counting across different areas, they looked at the busiest high-powered fields, so 40 times field. So 2 or 3 is usual, but 20% of people have 5 or more, and then once you get to 15, less than 1% of them had more than that, although you still occasionally find more T cells in those cases. So the range of what's normal for T cell count is quite high. Again, bearing in mind that ESC is for 1 millimeter squared, so that's probably about 4 or 5 high-power fields. You can see how you can end up with ESC criteria myocarditis even when there's a normal number of lymphocytes around. One of the other things we wanted is the criteria so far had always been about endomyocardial biopsies. We wanted to also cover other samples, so LVAD cores, like Joaquin mentioned earlier, autopsy and explant samples, for example. So we've got little CPORT, which is for biopsies, and big CPORT, which is for everything else. I'll go into this in a bit more detail. So the little CPORT you've got 5 grades from no myocarditis to severe, so 3 grades of myocarditis. Within no myocarditis, we've got an uncertain category. It's difficult to, from that graph you saw with the number of T cells in normal biopsies, it's difficult to provide an absolute cutoff value there. So we've got this situs, scattered increased T cells of undetermined significance. Big CPORT, so that's surgical and autopsy samples. You do need myocyte injury. We're back to Dallas-like criteria there, although Dallas wasn't ever on the surgical cases. And lymphocyte infiltrate of uncertain significance if you've got lymphocytes that are obviously abnormal but are not causing any damage. We don't quite know what they mean. And there are some qualifiers there, both in extent and temporally. In the UK and in the US, immunohistochemistry and autopsy material is a bit inconsistent as to whether it's funded and available, so there isn't any IAC requirement there. Plus, we don't have any real good data on use of immunohistochemistry in the autopsy setting. So little CPORT, we're back to Dallas, at least 5 biopsies of 1 to 2 millimeters. If it's less than 3, it's inadequate, but ideally it should be at least 5 biopsies. Examined at 4 levels, and a CD3 for most of them would be necessary. We recommend a CD68 and connective tissue stains to look for macrophages and fibrosis. They've settled on lymphocyte clusters, so rather than just what's there, whether they're sort of hanging around in groups with intent. And they could be on the H&E or on the CD3 stain. So a cluster, that's 5 or more lymphocytes, and each one is no more than 2 lymphocytes away from the next one. So they're quite closely packed lymphocytes there. If they're more than 2 myocytes distance apart, they'll be considered 2 different clusters. So cluster counting is important, but not so much individual cells. Still look for damage, and typically a datum to lymphocytes rather than separate. If it's separate, it might not be related to inflammation. And that includes dropout patterns. So sometimes if there's a lot of inflammation, you may see inflammation where a myocyte should have been. There's not a vessel in there. You might sometimes see a nucleus left in there, but sort of most of the myocyte has gone. Still concerned about reproducibility. And detecting damages can be quite subtle, and again, that's where we're concerned that it might still not be ideal. And don't count contraction bands. On the endomyocardial biopsies we get for transplant, most of them have contraction bands because of the procedure. So lymphocyte clusters, these are some examples from the paper. So 5 or more lymphocytes altogether. with or without any myocyte damage. So that's what we're looking for as lymphocytic myocarditis. They've got some nice pictures and better descriptions of myocyte injury in the paper. These are in cardiovascular pathology and are open access, these papers. So we've got some examples there. So single cell hypereosinophilia with lymphocytes around them, karyorrhexis, so with the chromosins fragmented, karyolysis, so you've lost the nucleus, and scalloping of the sarcolemma, so the little indentations with a lymphocyte looking like it's nibbling at the edges of them, the myocytes. So grading, let's start from severe. If there's an extensive, obvious lymphocytic infiltrate, there's clearly myocyte damage there, that's severe. You don't need any immunos to tell you that that's severe. Sometimes you might see occasional eosinophils, same as we do in the transplant biopsies. So transplant rejection is usually a lymphocytic myocarditis, and we do sometimes see eosinophils, but they shouldn't be a dominant cell type. For moderate, we're looking for multifocal inflammation with or without myocyte injury, which you record in the report. So that's at least 2 or more clusters of T cells, so 5 clusters of 5. And they can be in the same piece, they can be in different pieces, but 2 or more clusters. And mild would be 1 cluster with or without damage. There's also a second criteria for mild, which is a more diffuse infiltrate, a bit more like ESC. So looking for 15 non-clustered CD3 T cells in the busiest high power field. So that's when you start getting, this is in the less than 1% of the non-myocarditis biopsies have that. So this is almost certainly an abnormal, but not quite in the same clustering, and it's a bit more diffuse. And we're not quite so certain of that. If there are more than 5 but less than 15 diffuse CD3 positive cells in the busiest high power field, that's where we end up with cytus. So we've got the sort of 20% to 1% of normal. So it's in the highest end of the range we have there, and into the before you get to the less than 1% range at the top. So that's some examples of severe myocarditis. You can see it's at low power, lots of lymphocytes around. There's a CD3 in the bottom right panel, but you don't need that. It's obvious. These are examples of moderate myocarditis. So that can be, the cells can be on the H&E, they can be on the CD3, and sometimes, particularly if they're crushed, the CD3 can be helpful to identify them as T cells rather than endothelial cells, for example. These are all cases where there are two clusters in one piece for illustrative purposes rather than because they have to be there. They can be in separate pieces of your 5 biopsies. And this is the mild one. So on the left, we've got the clusters, and the top panel, the AB, there you can see it's not very obvious on the H&E, but when you do an immuno CD3, you can see those clusters there. And on the right, we're looking at the CD3 stains for the more diffuse 15 or more T cells in the busiest high power field, the mild. And then when you've got between 5 and 15, that's your cytus infiltrate of uncertain significance. Things not to count. Don't count lymphocytes in fibrous tissue. Don't count lymphocytes in endocardium. Don't count them in vessels or fat. So those don't count. It has to be T cells within myocardium. So just to run over that again, this is a sort of flow chart. Is there a fluid myocarditis? Yes. You're home and dry. You've got myocyte damage. You've got lots of lymphocytes. Grade 3, severe lymphocytic myocarditis. You can issue a report. If not, CD3 stain and counting clusters, 2 clusters or 1 cluster for moderate or mild, or going to your busiest high power field and counting T cells in that. And then you can split it into mild if it's more than if it's 15 or more, and cytus or no myocarditis, depending on where you are within that. So big CPOR, that will probably be more widely applicable. We don't get many myocarditis biopsies around. It's not commonly done in the UK. So in the autopsy setting, in the explant setting, LVAD cause, we'll go for big C-port. If you've got the whole heart, you should have at least 6 full thickness sections of myocardiums, so endocardium to epicardium, in 5 or 6 blocks. So quadrants of left ventricle and 2 bits of right ventricle in a block, or proximal and distal, depending on what you've seen and how which bits look abnormal, for example. These criteria don't apply to atria. We're less certain on how many lymphocytes is normal in atria. That's less well studied. So this is all just for ventricular myocarditis. They recommend, if you're doing an autopsy and you've got a suspicion of myocarditis, to keep an additional transverse section of heart so you can do more blocks. And because if you're finding inflammation but not damage, you might want to put some more blocks on to see if there's actually a damaging infiltrate there. Septal myectomy, we get those sometimes in hypertrophic cardiomyopathies, and they say at least 2 blocks of tissue for that. Usually they won't have myocarditis though. And the apical core, again, they say you'll put all the tissue through. I have to say, usually some of us keep just a little matchstick in case it turns out to be something like, it looks like it might be Fabry or something, and we want to do some EM. So the key criteria is myocyte lymphocytic infiltration, or myocardial lymphocytic infiltration with damage. That's what we need to call it myocarditis. And that's damage not explained by another cause, or infiltration not explained by another cause. And particularly in the autopsy situation, you might find some autolytic changes. So the myocyte changes with the inflammation need to be different from what you're seeing in the background. So this isn't just autolysis. They've called focal being a single area of myocarditis in one block, less than 50% of that block area. Multifocal, 2 or more foci in one block or in more than one block, but less than 50% of the block area, and diffuse being more than 50% of one of your blocks. And as I mentioned earlier, if you've got lymphocytes but no damage, it may be worth taking some more blocks to see if you can find it. And we haven't recommended immunohistochemistry. So there are 2 different papers for big C-port and little C-port. This one's got some different pictures for myocyte damage, just to show you some different examples. So the top one, we've got myocytolysis. We've got bits of myocyte left, but mostly completely destroyed. Lymphocytes within the cells on the bottom left, and the scalloping on the right with the myocyte with the arrow looks a bit more hypereosinophilic, and it's got little scallops on the outside. You can also see some vacuolar degeneration, so holes within the myocytes associated with inflammation. And that's just showing it's a lymphocyte infiltrates of uncertain significance. These are quite common in forensic autopsy cases that they've died of something completely different, been hit by a car, they haven't died of myocarditis, and you do find lymphocyte areas in that, even focal myocarditis, not uncommonly. And then looking at temporal qualifiers, so is there any granulation tissue? If there's just inflammation, not granulation left, yeah, that's acute. Started to get granulation, subacute, and then we've got mature replacement fibrosis. There's still some inflammation around, there's still some myocarditis, that would be chronic. Burnt out myocarditis is a difficult one to define completely. We talked about dilated cardiomyopathy earlier. So they haven't got ongoing inflammation, they've got some fibrosis. Could this be myocarditis? So the things that the clues that point you towards that might be the case would be the position of the scarring. So subepicardially tends to be favoured in myocarditis. If it's a subendocardial area of scarring, it'll usually involve those few subendocardial myocytes. So ischemic scarring, you've got that subendocardial sparing, but in myocarditis, those will be taken out by the inflammation quite often. And myocarditis versus ischemia. Ischemia will usually follow a arterial territory, particularly it's a major coronary artery disease, whereas the myocarditis will be more diffuse and spread out through the heart. You also get the secondary changes we heard about in dilated cardiomyopathy, so ventricular dilatation, hypertrophy, and interstitial fibrosis. This morning we had topics on the topic and on the subject, and then on cause as a cause of death. This is quite hard to do for myocarditis. How much myocarditis is enough to be the cause of death? Well, it's difficult to say, and it depends on so many other things. So, as I mentioned, if somebody's hit by a car and you find a small focus of proper, definite myocarditis, that isn't their cause of death. So it depends on so many other different things. If they've got extensive and severe inflammation and no other obvious cause of death, then it's entirely acceptable to put myocarditis as a cause of death. If it's focal, it's less certain. There probably is some arrhythmogenic potential, and sometimes it can affect the conducting system, so that would push you more towards a myocarditis cause of death. Cardiomyopathy, so going back to the DCMs again, cardiomyopathy, including arrhythmogenic cardiomyopathy, can present with episodes that look like myocarditis, and it's beginning to get more and more complicated as we're going through. And the other thing is, in patients who've been in hospital, don't get caught by inotrope effect, where you might find individual myocyte damage with usually macrophages around it, and you can get the same as cocaine. CPOR isn't the end of the story for this. There's still things we don't know, so there'll be another. Give it a few years, there'll be another criteria set coming through. So we've given you a histological grading system. Is that actually of any clinical relevance? That was always one of the problems with Dallas, was that did it actually predict outcome, or is this just sampling error? You know, sometimes you'll get the worst bits, sometimes you'll get not such bad bits. What does the situs and linus actually mean? What's the relevance to the patients and their treatment? What are our cardiologists going to do with that? Histocytic myocarditis, again with COVID, we had those cases with an awful lot of macrophages. Is that just a non-specific thing, or is there actually histocytic myocarditis? We don't know yet. Beyond giant cell myocarditis, we'll talk about that in a bit. How much is enough for cause of death? We'll never be able to give you a certainty because of the other circumstances, but how much is it reasonable to use myocarditis as a cause of death? These were largely written on an adult group. The recommendation is that we could use those in the pediatric group as well, but they do need further study to understand whether they're actually relevant. And also, can we determine the etiology of a myocarditis by the pattern of infiltration? From a clinical point of view, there's a progression in the same way as we had the acute, subacute on it. So acute would be defined as up to 4 weeks in duration. And as that nice slide from, I think it was Joaquin, often starts with viral myocarditis. That's the commonest cause, presumed cause. It's often not proven. So you start with viral injury, but then there's exposure of the cells to the immune system, proteins to the immune system, and then you end up with an autoimmune progression in some cases, and you end up with a subacute phase up to 3 months. And then some patients will go on to a chronic phase of over 3 months, and that's where you end up with the dilated cardiomyopathies in some cases. Prognosis of inflammatory cardiomyopathy. So these are cases with myocarditis and cardiac dysfunction. So presentation, sometimes you'll see infarct-like myocarditis. So that's patients who present with chest pain and often some cardiac dysfunction. ECG changes as well, so it looks a bit like an infarct clinically. Can present with arrhythmias, asymptomatic, and we do have patients who present with heart failure and no obvious cause. Over half of them, if you do nothing, will still get better. A quarter, there you go. The non-dilated left ventricular cardiomyopathy, so that's the non-dilated dilated cardiomyopathies, or have some left ventricular dysfunction but stable, and some of them will go on to needing ventricular assist devices, transplantation, or all die of their disease. Now, we started off with some acute dilated cardiomyopathies had inflammation, but as we're doing more on the genetics, we're finding that there's some of those sarcomeric and desmin proteins, alterations in those, variants in those, are associated with myocarditis. So we're actually getting back to the point where some of those have the same genetic problems as in dilated or arrhythmogenic cardiomyopathies, but that's predisposing to myocarditis. So it's still very poorly understood now, but maybe that's one of the second hits from what Rob was talking about. So you've got incomplete penetration. Maybe some of that it's the myocarditis is the second hit. I don't think we know that for certain, but there's a more complex interaction there than some dilated cardiomyopathies are genetic and some are myocarditis. There's a big grey area in the middle. The ESC have some other recommendations. I've picked out ones that I think will be relevant to pathologists. So they recommend endomyocardial biopsy in high risk of myocarditis, which they've given definitions of with hemodynamic instability, for example, or if they're not responding to therapy, or you're concerned that it's one of the unusual types of myocarditis, like giant cell myocarditis or eosinophilic, so they've got a high peripheral eosinophilia, or you want to prove there's virus in myocardium to prove it is viral etiology. I have to say, we don't do that much in the UK. I don't think it changes management for most patients, so we don't routinely do it. Other places do it more, and they would tend to be the places who are more involved with the developing the criteria. Genetic testing. So they've got some slightly vague recommendations on genetics. So, but genetic testing should be considered in patients with definite myocarditis or pericarditis in cases of severe ventricular arrhythmias. That's our autopsy cases, isn't it? I think some of them will have heart failure, but those will often be signed out. It's the ones that are sudden death and myocarditis. Might be worth thinking about genetics in those cases. Not yet recommending we do it, but certainly consider it. And on autopsies, the first of those is recommending autopsy for sudden death under 50. We all know that, and maintaining samples for DNA, and consulting a cardiac pathologist where an inherited cause is suspected or cause of death remains unexplained. So if you've got a patient who's died sudden cardiac death in a young patient, it may be worth putting some spleen in the freezer or other material for genetics, because you won't usually know it's myocarditis until you've seen the histology anyway. So you'll have that material already. You can start going into family history, and if there's any reason to do family screening. And they also recommend endomyocardial biopsy with patients who present with rapidly progressing myocarditis for giant cell myocarditis. Loads of different causes of myocarditis. We've got parvovirus that we have mentioned earlier. I don't think beer drinkers is on there. Oh, alcohol is, but not heavy metals. That's your cocoa one. So yeah, there's loads of different causes there of it. I'm going to talk a bit more about immune checkpoint inhibitors, but one of the drugs on there is clozapine. And that's something that comes up in lots of different things. And I thought one quick rabbit hole into clozapine is so it's an antipsychotic drug used usually when other drugs have not worked for patients who've got psychiatric disease that needs it. It's quite, I think it's an effective drug, that's my understanding, but it's also quite a risky drug. And it can be important in autopsies for a number of different reasons. So it can cause myocarditis, usually in the first couple of months of treatment. Egg granulocytosis is quite well known, so predisposing to infection, and patients should be having really very regular full blood counts. First week for 18 months, sorry, for 18 weeks, every fortnight, and then every 4 weeks after that. The other one that's come across coroners have expressed concern about is pseudo obstruction, fecal impaction, stercal perforations of the bowel, and peritonitis. So deaths from pseudo obstruction with clozapine. I have had one of those, but that's a potential cause. If you've got somebody with paralytic ileus on clozapine, that might be the cause. Toxicity, there's loads of different ones. Symptoms of that, but coma, convulsions, respiratory arrest, aspiration, can be associated with serious infection. if somebody's got on another drug that interacts, or even switching from cigarette smoking to vapes or stopping smoking. So cigarettes cause enzyme injection, stop smoking, switch to vapes, you lose that, and the clozapine levels can go up, can end up with fatal toxicity from that. So that seems innocuous, but that can trigger fatal toxicity. Back to myocarditis. So immune checkpoint inhibitor myocarditis. Some tumours evade the immune system by expressing PDL1, and we see that we do immunohistochemistry on our lung cancers for that. So it binds the T cells and knocks them out. So it's a bit like a sort of cloaking device. It hides it from the immune system. And if you block that with drugs, then you open up those tumour cells to immune attack. Patients on these drugs get a wide variety of autoimmune conditions. Most of them will get some sort of thing. Usually it's a bit of colitis, and apparently that's usually mild and easily managed. Myocarditis is rare, only 1% of patients get it, but the mortality is high, so it's important to know about. Usually within the first couple of months, there can be even a year or so after, or more after starting treatment. We have one recently which was sent as triple M syndrome, which I had to look up, which is some of these patients get a combination of myocarditis, myasthenia, and myositis, so lethal muscle problems. This is a nice paper that looked at a series of 10, none of the series are very big, so a lot of them don't get biopsies. And they found in these immune checkpoint inhibitor myocarditis, lymphocytic myocarditis. Most of them met Dallas criteria. So this is pre-Seaport. And this is a fairly recent paper. Dallas is still there. Macrophages are quite common and more frequent than you see them in rejection. The high-grade ones, like severe lymphocytic myocarditis, severe rejection, often have a few eosinophils around, and you get some PDL1 staining of macrophages and myocytes. In this, as with ischemia, you can use a C4D, which can label damaged myocytes. So on the figure there, on the right, you've got rejection, and you've got what they've described as high and low grade immune checkpoint inhibitor myocarditis. The high grade being obvious, and the low grade being less obvious lymphocytes. And they split these into two groups based on thresholds in the number of CD3 cells, CD68, time before the patient was biopsied, and eosinophils, for example. I'm not going to go through them all, but the ones had the higher criteria were in the red. All of those 3 patients died. The 7 who didn't have so many of those features, they all survived. So histology does seem to predict outcome in these patients. Another little, we mentioned COVID earlier as sepsis in the heart. So this was another rabbit hole I went down. So sepsis-induced cardiomyopathy, it's presumed to be transient and has no cause other than sepsis of somebody's cardiac output falling. This is another child of the 1980s, a bit like most of Mike Davies' work on coronary arteries. That seems to be in a golden era of cardiac pathology. So recognised in 1984. So they recognised that patients who had a dilated left ventricle, reduced left ejection fraction, had a worse survival than septicemia. I suppose it seems obvious, but it's there. So it seems to be part of an exaggerated inflammatory response, like we have with COVID. Multiple different media, some of which are reactive oxygen species, cytokines, and so on, cause direct myocyte toxicity, so affecting calcium channels and mitochondria, and indirect, so things like hypertension, and the catechlain is used to treat that, leaky capillaries, and so on. So with that, you can see histological changes in the heart and sepsis. So that's mainly macrophages interstitially. You can also get some endothelial cell swelling, so CD31 can be helpful, and ERG to differentiate the two. Can find neutrophils, contraction bands, particularly with inotropes, that's more an inotrope thing, and sometimes edema, so separation of the myocytes that isn't just artifactual. With chronic sepsis, you can get some interstitial fibrosis, which would be less reversible by that time. Just going on to some of the other types of myocarditis, so giant cell. This was a endomyocardial biopsy. This man presented with some conduction defects, mid-50s, I think he was. Not in particularly in heart failure, but seemed to be progressing. They initially thought this was going to be sarcoidosis because of the conduction system being early, and had an MRI which showed a bit of late gadolinium enhancement, so inflammation, fibrosis. But on the biopsy, top left, you can see really obvious inflammation. You don't just about need a microscope for that. Top right, lots of here lymphocytes. That's probably the dominant one, but with giant cells around as well. So the bottom panels, you can see giant cells in there quite frequently. The stain on these, so these were sent to me by somebody else. But there are a lot of eosinophils around too. So that's a fairly typical feature of giant cell myocarditis. So giant cells close to myocytes, often lots of eosinophils in the background. The bottom left one, you can see some of the myocyte damage. There's a myocyte. Yeah, so it's got the vacuolar degeneration I showed you earlier on there for myocyte damage. And there's obviously some fibrosis going on. This has been going a little while. Different case. This is an explant case. Presumably they've got some sort of conduction problem because they've had a pacemaker. There's a little hole there. Pacemaker goes in. But patchy white fibrosis within the left ventricle septum and in the right ventricle there as well. Did wonder about whether that was going to be arrhythmogenic, but it's not quite right for that. And down the microscope, there are some fairly well-defined granulomas with a rim of lymphocytes and fibrosis around those granulomas there. And in other areas, there were just sheets of replacement fibrosis, possibly with a granuloma at the top there, I think. But not much inflammation, a lot of fibrosis. So that's cardiac sarcoidosis. The two can cause some confusion and some difficulty separating them out. So in giant cell myocarditis, the giant cells are often near the myocytes. They're active participants. In sarcoidosis, they're sort of sitting with their friends in granulomas. Eosinophils are common in giant cell myocarditis, but not sarcoid. Lymphocytes, florid in giant cell, sitting around the granulomas in sarcoidosis. And the amount of myocyte injury that you're seeing is much higher in giant cell myocarditis. It's a much more rapidly progressing. Sarcoidosis is slowly progressing. You do lose myocytes and they're replaced by fibrosis, but it's not quite so active. And the other thing that helps with sarcoidosis affects the epicardium, pericardial, as well as the myocardium, whereas giant cell myocarditis will generally stick to the myocardium. Well, there was a case presented, I can't remember who it was, some Japanese pathologists, and they would always take a bit of skeletal muscle, and they had somebody with giant cell myocarditis, and they had the same in the skeletal muscle. And I don't ever routinely take skeletal muscle, so I wouldn't know where you'd find that commonly. Granulocytes can be seen in myocarditis. So eosinophilic myocarditis is probably best known. Drugs, parasites, hypereosinophilic syndromes like Churg-Strauss. So you see eosinophils and Charcot-Leyden crystals, which I accidentally found out. I didn't discover it, it's already known, but they stain with Zn. So if you're looking for Charcot-Leyden crystals, they'll stain with a Zn. So you start with inflammation, progress to endocardial thrombus, and end up with fibrosis and a more restrictive pattern. I don't think I've ever seen one that's gone to that stage, actually. That's the description. If there are lots of neutrophils, make sure it's not an infarct, because you'll get neutrophils as a response to an infarct. But if it's patchy, we're looking more for infective endocarditis. So that might be in transplant patients or immunosuppressed patients who've got fungal disease. And I've also seen one where they've got small bacterial foci in somebody who's got severe sepsis. And I'll just do a brief advert before I finish. So if you like what you're hearing today, the European Congress of Pathology, lots of different pathology disciplines, but that does include some cardiovascular, and that's in September. The next AUCVP meeting is in 30th of September, 1st of October next year, so not this year, next year. And I believe the best case presentation here the winner will get £300 towards going to Athens. So yeah, it's in Athens. It looks like it's going to be a great venue and hopefully a good program. And for forensic pathologists, there's some cardiovascular elements in the International Association of Forensic Sciences in Sofia in May this year.